So my task is to see whether we can use DCB in calcified lesions. So the objective of my talk is to show some data, more importantly focus on the technical aspects of the procedure, and maybe show some cases. So let's look at the data. I mean, in terms of stents, we all know calcium and stents don't do very well, and the calcium is an independent risk factor for stent failure. But it's not just the calcium in the real world. It's the diffuse nature of the disease, small caliber vessels, then systemic factors like diabetes and renal failure makes the whole case very complex, and the stent failures are very high in these kind of patients. What about DCB in calcified lesions? One of the advantages DCB gives is that it maintains the original artery anatomy, so it doesn't cage the vessel, so there is no nidus for stent-related events in the future, and of course, a reduced DAPT duration we just discussed in the last lecture. So leaving nothing behind is exciting. So what is the evidence so far? So this was a paper, I think they showed it yesterday. It's from Japan. They looked at the predictors of target lesion failure post-DCB in de novo lesions. And as you could see, advanced renal failure, patients who are on hemodialysis are at a high risk of failure. And if you look at the lesion characteristics, calcium was an independent risk factor for a lesion failure. So this is another trial from China which looked at the propensity matched analysis between patients who had calcium and patients who didn't have calcium who had the DCB. And you could see there were no difference in the hard endpoints, but if you look at the revascularization rates, were higher in the calcified lesions. So calcium is also bad for DCB, but for me, calcium and DES is more bad than calcium and DCB failure, because once you put a stent, and if you don't treat it properly, the calcium behind the stent is very difficult to treat. Whereas if it's a DCB failure, you can go back and put another DCB or maybe put a stent. But there is a very little data comparing DS and DCB in calcified lesion in terms of powered studies like RCTs. But again, we discussed this yesterday that in solution de novo trial, there is some kind of sign or indication that maybe DCBs are better in calcified lesions. But of course, this needs to be tested in a larger population and randomized trials. So in my practice, if someone says, I don't use DCB in calcified lesions, I don't need to do angioplasty because we hardly do type A lesions these days. Every case we do has some kind of calcium. So for me, calcium does not deter the choice of device if the DCB suits the lesion and the patient subset, which are diffuse disease, small vessels, bifurcation, and high bleeding risk patients. The aim of DCB angioplasty is to minimize the stent length and to avoid stents when we can, especially in certain lesion and patient subsets. So let's look at the more technical aspects of the DCB angioplasty. So one of the most frequently asked questions is, can the drug be transferred through a solid calcium barrier? And for that, you have to prepare the lesion and induce lots of fractures, and for that, you need an intravascular imaging. The other problem when it comes to calcified lesion is after balloon dilatation, because in a non-calcified lesion, recoil can be addressed or it will be less. And even if there's a recoil, if you're putting a stent, you don't have to worry. But if you're putting a DCB, you have to address the recoil. Same with the dissection. If you're very aggressive in trying to prepare the lesion, you tend to have a flow-limiting dissection, and it's more common in calcified lesions. So when it comes to pre-dilatation, I always start with an NC balloon, and I go for 1-to-1 balloon-to-artery ratio based on the angiogram. And what do I do when I pre-dilate the lesion? I'm looking for two things. I'm looking for a uniform balloon expansion, and I'm looking for a wire position within the balloon. So let's look at the uniform balloon expansion. So this is just a case of a LAD and the circumference. You could see the balloons not expanding uniformly. Clearly in that LAD, there is a dog boning. So when we did the intravascular imaging, there is a concentric napkin ring of calcium. So obviously in this case, we used an IBL, and we had excellent fractures and a lumen gain. And obviously we used a DCB here with a good result. The next is wire position. So what do I mean by this? So for example, if you look at this, this is a LAD diffuse calcified disease, and we wanted to avoid stent here. So we did a balloon dilatation, and you can see here all the balloons expanding. Look at the position of the wire within the balloon. It's very, very eccentric, which meaning that the balloon's expanding where there is less resistance, not where there's calcium. So in this case, we did intravascular imaging, which confirmed an eccentric calcium. And we used a cutting balloon. The key in the cutting balloon is to take the balloon downsized by 0.5 on the IVUS, and you have to go high pressure, 14 to 16 or 20 atmosphere. And look at the position of the wire within the balloon. It's completely changed because you crack the calcium, wire has become more central. And we confirmed this with the intravascular imaging showing lots of cracks. And finally, the recoil. As I said, if you are going to put a stent in, it's not a big deal because the scaffolding will take care of the recoil. Whereas if you're going to go for a DCB, you have to do more work. And I'll show you a case. So this is a circumflex CTO post-bypass. So this was crossed with a CTO wire, and after that, we pre-dilated with a long NC balloons. And we generally keep the balloon for at least 25, 30 seconds. And after this, we had a result like this. Most of the circumflex looks okay, but look at the ostium. I'm not very happy to put a DCB here. For a stenting, maybe it's okay. So what I did was I took a cutting balloon, 3.5, 16 atmosphere, left it for 30 seconds, and we had a result like this. So if you appreciate the ostium, there is less recoil. And if you look at the post-NC and post-cutting, you can see the difference that the recoil is much better. So this is now ready for DCB. That's what we did, 2 DCB in this case. And that was the final result. The other problem we encounter when DCB using calcified lesion is when to consider bailout stenting. So for me, again, it's a persistent recoil, or if there is a flow-limiting dissection, I go for a stenting. So let's look at the persistent recoil, because when you have a recoil, do you want to stent the whole length of the lesion treated by DCB, or you go for a focal stenting? I go for a focal stenting. I'll show you a case. So this is a very diffuse LAD diagonal disease. So after lesion preparation, we used 3 long DCBs. So 2 in the LAD and 1 in the diagonal. And post-DCB, we had a result like this. Again, look, it looks great, but if you look at that area, there is a focal recoil. Now, rather than placing a long stent, we placed a very short, like 18 millimeter stent, and we got a good result. So we got the benefit of the DCB, but also we addressed the recoil with a short stent. With this, I would like to show a couple of cases. So this was done in Hong Kong, one of my friend's hospital in Hong Kong. 49-year-old presented with florid pulmonary edema, big troponin rise, and a cardiogenic shock. He was a chronic smoker, a diabetic, and his LV function was 20%. And he had an MRI scan which confirmed ischemia in the LAD and RCA territory, and it was also viable. So after stabilizing with furosemide and CPAP and everything, once you got more stable, we did the angiogram, and you could see the RCA is diffusely diseased, and there is a flow into the LAD CTO. And this is the LAD CTO, and circumflex was relatively okay. Now, in my unit, I would have done a DCB in the right coronary artery because this patient is young, diabetic, he's got all recipe for restenosis in the future. But in Hong Kong, that's still very early on in the DCB experience, so we put a long layer of stent here with Impella. And in the same setting, we did the LAD CTO, so we crossed with the Gaia 2 next wire. After crossing, we just did some ballooning and did an IVUS, and you could see there's a diffuse disease and lots of calcium. So obviously, in this case, we rotablated the LAD. After rotablating, we ballooned the distal segment, and proximal and mid-segment we had to use IVL. And after that, we had a lot of fractures in the LAD, and more importantly, there's a lumen gain. And for me, this is the important picture. This is post-pre-dilatation. The flow is STEMI 3, acceptable recoil. So for me, this is ready for DCB. So we used 2 long DCBs here. And we had, again, acceptable result. Now, if you're a stent enthusiast, this doesn't look great because cosmetically it doesn't look nice, but we refrained from doing any other work in this. Now, patient had some chest pain a few months later, so he came back for an angiogram, and they all thought it was a DCB failure. So they did an angiogram. I wasn't there. I had left Hong Kong by then. And you could see the LAD looks okay. But the problem was the right coronary artery. There was a stent fracture at the right of the hinge movement, and we had to put a stent here. So if I had used this without a stent, maybe it would have been okay. So the second case, we did this live case at our calcium meeting this year. Me and Dr. Colombo did this case. So RCA, heavily diseased, tortuous, calcified. Again, a patient with all risk factor for restenosis. So this was very difficult to wire, so we had to use a microcatheter, and it was very difficult to spin the microcatheter, a lot of calcium. So obviously, we did a 1.5 burr here. After the burr, we did a balloon dilatation, long balloons. And after this, we did the IVUS, which showed lots of fractures and lumen gain. And again, this is a picture to see. This is post-POBA and post-rotablation. Look at the artery. It's very minimal recoil. Now, we checked the lesion length. It was 80 millimeter. So we would have put an 80 millimeter stent here. So a lot of people in the panel didn't agree that we should use a DCB, but we went against the panel and did the DCB in this case. We put 3 DCBs. We had a good result here. Again, no recoil, no flow-limiting dissection. So we accepted, and patient had angiogram 8 months later at our request. And look at this. For me, what's striking here is, look at the artery anatomy. It's fully maintained. It's not being caged. You still see that hinge movement of the RCA. So in conclusion, calcified lesion per se is not a contraindication for DCB. Lesion preparation is the key and should be aided by intravascular imaging. You have to use a specialized balloon in cases where you need to, so guided by the intravascular imaging. And careful assessment post-DCB for recoil and dissection. As I said, if you have a recoil, you can address it with a short stent rather than going for the whole length of the treated segment. And dissection, again, if it's a flow limiting, you have to fix it. But if not, please accept it, because we had some beautiful cases yesterday shown by one of our Japanese colleagues. So bail should be kept minimal. Thank you.